Hey, Navigator Nation, it is Mike. How is it going today? Today is, of course, Thursday. Oh, I knew I forgot to do something. I forgot to update our little graphic thing on the side of the window here. Every time I think I got everything all squared away in the workflow, I missed something else. So today is actually April 16th. I don't know if I can fix that. I guess I could fix it real quick here. Hopefully that will be the worst thing that happens today, April 16th, 2020. And we'll see if we can get the right font in there. What is that called? Futura, I think. The fun things that you don't catch until it's too late. We'll give a little bit of a blue background there and see. Whoop, that's not the right color. Give it a little bit of a blue background. And we'll pretend that that's the thing. Didn't do the background, but we'll just tuck it in right there. There we go. All right, Navigator Nation. It's a pretty little tree. Happy accidents, no mistakes, right? My name is Mike Hess. I'm a respiratory therapist. I'm having some fun today. It is still a little bit of a cold day outside, but we still got some sun shining, so that's good news. This is COPD Navigator House Call, our live show that we've been doing at right around 4 p.m. Eastern Daylight Time. Each weekday during this coronavirus pandemic, as we're all on our stay-at-home, stay-safe orders and quarantining, whatever words we want to call on it. Of course, been kind of a controversial issue here in Michigan. We had a whole bunch of people who I'm not going to comment on, but decided to break this order and congregate at the Capitol in some kind of protest. And so now we're probably going to be leading the second wave of infections coming up in anywhere from 5 to 12 days from now or so. Take this stuff seriously, folks. Please stay at home. Karen checking in on the feed here. Yes, it has definitely been tough. I get that. I know I don't say any of this stuff lightly, only lightly enough to try and put a smile on some people's face, because this is a very tough situation, and we got to try to have at least a little bit of fun with it. Normally we have our show every 2 weeks called Breathe TV. We've got a Facebook group called COPD Navigator. We've got a YouTube channel called COPD Navigator. We've got a Twitter feed called COPD Navigator, which is offline today just because of some quirks in the tech, similarly to what we see in the date range there. But we've got some other stuff on the agenda today. Hello to Joe. Hello to Tanya checking in. Appreciate you stopping by. We've got two main ways to get questions going here. I guess technically three. You can get questions in on either the Facebook page, which is, believe it or not, COPD Navigator. You can check us out on the YouTube channel, also called COPD Navigator, or you can find a watch party in a couple of different Facebook groups. One of them, of course, our group that is associated with the page, which, you guessed it, is called COPD Navigator. Also have a watch, so that's where the watch party's going. So if you're seeing some questions come through that you don't necessarily see where they're coming from, or want to interact a little bit differently, you are, of course, absolutely welcome to try one of the other methods, and we will get attention to your question or your comment as soon as possible, just like Jerry waving at me from Minnesota. So thank you for checking in on this Thursday. Hope things are well wherever you're at. We don't necessarily have a fixed topic of the day. We talk about anything from COPD to this novel coronavirus, SARS-CoV-2, COVID-19, the disease that comes from it. We talk about inhalers. We talk about all kinds of stuff. This is really your time for the most part, so please feel free to get those comments in whichever direction your particular comment field is. And again, we will get attention to them just as soon as possible. One thing I do want to highlight today, I saw an interesting article on one news site that led me to another place. There is an app out there called Achievement, and if I can get my tablet to unlock here, there's an app out there called Achievement, which I have seen a little bit. I haven't really messed around with it too much myself. It's got some pros and cons. Hey, John, checking in from another one from Minnesota. I wonder if you and Jerry know each other there. So there's this app. There's this whole theory in healthcare right now about this idea of gamification, where to put it, I guess, kind of bluntly, you're actually kind of bribing people to take their meds and adhere to their regimens and all that stuff. And sometimes it works out great. I mean, you can get rewards. I mean, I've seen different programs that give you Amazon gift cards or gift cards to local grocery stores or other shopping or all that kind of stuff. Can work pretty well, and we all do well with some kind of encouragement. And one of the ways that happens is through, feeling like turning it into kind of an adventure. We've all played various games growing up, and those of us who are in kind of the geekier generations perhaps grew up on video games, and we kind of respond to that kind of stimulus, or stimuli as the case may be, because it comes from various places. So this idea of achievement, you can earn points for doing stuff. You can earn points for walking. You can earn points you can connect it to some of the fitness apps that are out there. You earn these points for various things, and you can get rewards for them. Like I said, these gift cards and all that kind of stuff. The downside to it is, of course, you're providing data. I'm going to say we call it the downside, but it's more of like a downward incline, I guess. It's not necessarily like dark side or anything like that, but you're giving up your data. The upside to the downside, one of those things where, well, we know that they know that we know that they know. But the upside to the downside is we can, as healthcare providers, we can kind of take that information and consolidate it into various trends and stuff. And so that's what's been going on. This company that runs this app, this achievement app, is called Navigator. They happen to have their website here. If I can get it out of the glare. So Evidation, and they've kind of collected a lot of this information that they've gotten through the app, and we're noticing some trends. And some of it is self-reported, like I said. Are you taking your meds? Are you doing your thing? Some of it is connected to fitness apps. So as we get through this, this is where the data is coming from. As you might expect, there are they give us some information about where the information comes from. It's open to any member of Achievement, with nearly 4 million people participating with this thing. Nearly 185,059 participants in this particular study. So it does look like this was a thing. Okay, so this is COVID-19 Pulse, is what this is. This is actually a separate project that they're doing that you did have to opt into. So that's good. I guess there is no upside to the downside. This is just the way it is. 96% of U.S. counties, which is good, all explicitly opted into sharing their responses and historical activity data in aggregate for this specific program. So what we're looking at is this is fairly on the up and up. Like I said, this isn't necessarily the dark side to social media where they're just collecting all this information or the cookies on the websites or all that kind of stuff. So they did ask some questions, and the latest update is probably the most concerning to me, at least, where they're saying in the question was, in the past 2 weeks, have you experienced any of the following with regards to your general or ongoing medical care, the things that are not related to coronavirus, for example, COPD maybe, and 33% of the people of those 185 odd thousand respondents, actually for this one, this was 88,000. So this data collection ended on the 8th. So it's about a week old, but that's pretty fresh as data goes. 33% have mentioned that they've had to miss or cancel a previously scheduled appointment, or they're unable to get in-person appointments to see their provider. So that's 1 in 3 people having disruptions to their care. Now, in some cases, we've been able to counteract that with things like telehealth. And I see my good friend Gene Gant checking in, telehealth expert from down in the great state of Tennessee. Some of that we've been able to counteract these in-person cancellations with these virtual visits. My wife is a nurse practitioner that works, as many of you know, she works in metabolic and bariatric medicine, and she has started doing telephone visits and virtual visits where we actually have two-way communication. It's kind of like a teleconference, a secure teleconference through your health record. And that has been working fairly well in a lot of cases. It can work fairly well, and as the technology matures, it's going to work better and better. However, we still have a lot of barriers to that. I mean, obviously, if you're watching this right now, you're pretty familiar with computers and technology and how these video conferencing and streaming and all that stuff works, but that doesn't apply to everybody. Not everybody opts into their electronic medical record. I know most of the people I usually see in person have actively declined to participate for various reasons. I mean, I'm not saying that's a bad thing. I mean, everybody's got concerns. Electronic medical records can be great. They can be terrible. I mean, there's a lot. It's not a judgment call by any stretch. It's just a barrier. There are people who don't have consistent internet access. There are all these things going on. So telehealth it will be great, but right now we still have a lot of ground to cover as far as developing that. And there are certain things that can't necessarily be done face to face. Like, for example, I have this device. We've talked about this a lot in the past. This device is called a in-check dial. What this does is this measures your inspiratory flow to make sure that you are using your dry powder inhaler correctly. Obviously, I can't hand this through the computer screen and have you blow on it like I can in my office. So it's difficult to get that evaluation unless... Sorry, banging around a little bit. At some point I'm going to learn or get a bigger studio, I guess. So it's unless we're at a point where we can distribute those to all of our COPD folks, it's hard to get that kind of evaluation. Now, I was watching, they had a really good webinar. Nursing expert by the name of Dr. Margaret Fitzgerald has a director of nursing or a doctorate in nursing practice and credentials as long as my arm. Does a great job with training and teaching and test prep and all that stuff. One of the most renowned experts in nursing in the country gave a webinar today that was really fantastic about, in general, the coronavirus, this novel coronavirus itself, coronaviruses in general, the disease that comes from this COVID-19, a lot of these words that tend to be used interchangeably, but actually mean different things. And talked about telehealth as part of that. So if I were doing a telehealth visit, I could, if we're having an interactive thing where I had like a Zoom conference like we had with Right to Breathe the other night, I could be watching your breathing pattern. I could asking you questions to see if you can complete full sentences. I could be watching you cough. There's a lot that I can do. And we used to have a lot of these things before we had gadgets like the InCheck or like the aerosol inhalation monitor that I use a lot. There are ways to overcome this stuff if we have telehealth capabilities. So, and Tanya's mentioning my pulmonologist phoned me to see how I was doing. She did that for those who had appointments during this stay at home. I've been doing that myself, checking in. I've been kind of going week by week with people who have appointments with me. Instead of what I actively chose to do was, instead of calling everybody a month ago or whatever and saying, well, your appointment for the next month is going to be canceled. I've been kind of going week by week and touching base with people and doing kind of an informal visit. Due to some of the complexities of respiratory therapy and reimbursement and all that stuff, I don't necessarily get paid for that, or my facility doesn't get paid for that. So it's been difficult to have formal telehealth visits, but I can at least check in on my people like Tanya's pulmonologist is doing. And that can help. It's been nice to actually have some connection with my people because, I do still like to be a clinician from time to time, just as much as I like to do all this stuff too. John asks, mention patients who are not participating in EHR access. Do you feel that patient pushback is hurting acceptance and progress in telehealth being more prevalent? Not really. I think the biggest issue has been reimbursement. The reason that, for example, my wife can do telehealth now is CMS in particular, the Center for Medicare and Medicaid Services, has issued emergency guidance through this to allow telehealth visits to be more reimbursable. Payment has been a big issue because it's not necessarily patient pushback. I think it's policy maker misinformation or ignorance in the non-mean sense, just not knowing a thing. I don't think they've understood properly how important and how practical telehealth can be. A lot of what I do, particularly with things like smoking cessation and things like that, is truly counseling. It is me putting all the gadgets aside, sitting and talking and finding goals and finding solutions and getting people on the path to using their medications appropriately at the right times and all that stuff. For as much as I love my gadgets and for the information they give me, arguably 80% of my visits in most cases outside of diagnostics are sitting and talking. That's why it's so difficult to get doctors to do that, because they don't have, or not just doctors, but providers to do that, because they don't have the time to do that, but I do. Similarly, what my wife does, she does a lot of nutritional counseling and a lot of talking and goal setting and all that stuff, things that do really lend themselves well to this kind of setting. And then that way you don't have to worry about transportation. You don't have to worry so much about taking a lot of time off work to drive to an office. She's got people who come in from from 45 minutes away, an hour away. And similarly, in my practice, we have a lot of people who have to schedule rides in advance or make sure that they're catching the bus on time. We have a lot of those transportation barriers. So telehealth can be a really practical way to do that. And I think we're seeing that I think most patients are really pretty supportive of that. when we explain to them the pros and cons of it. Of course, we do have to fight some misinformation sometimes. We talk about, well, are all the Russian troll farms, are they going to steal my data? Or, are these all these black hat hackers and all that stuff? Are they going to watch my medical, my encounter, my appointment, and then all of a sudden I'm going to get all these ads for pills and inhalers and all that stuff? And when done properly, when done in accordance with best practices, that stuff doesn't happen. Again, we do it through the EHR or through a similar program because it's secure, because it's all that stuff. And so when we explain that, that's very accepted. Again, I think a lot of the actual barriers to adoption are related to either policymakers and payment reimbursement, or the fact that, as much as we pride ourselves on our technology infrastructure, there are a lot of people who still, believe it or not, don't have access to a lot of this stuff. And it's not even just necessarily what we call poor people or anything like that. It's rural communities who really don't have anything approaching high enough speed internet to allow two-way video conferencing. So, sometimes it's folks who have these connections have trouble streaming Netflix just one way. I think those are the bigger issues personally. I think those are things that just take time to overcome. We need a better rollout, and we need a more robust connectivity and all that kind of stuff. And these are kind of the things that I hope people are noting, especially in public health, because the after COVID-19, the post novel coronavirus world is going to have tremendous opportunities for process improvement. What we're seeing, these barriers of access and things like that, we know in many cases that they have been there, but they've been kind of hidden and relatively easy to ignore. This pandemic has really highlighted where a lot of the breakdowns in our system are. For example, we talk about stockpiles, and this is not going to be political. I'm not trying to get controversial or anything like that. We talk about having enough stockpiled supplies, especially masks, gloves, all that stuff. Well, for a number of years now, many hospitals and many healthcare organizations have been pushing kind of this idea of what they use in the business and manufacturing sectors, like just-in-time ordering, because, if you have too much supply, then it's just taking up space, and it's a waste of money, because what if you never use it, and blah, 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 blah. Well, now we're kind of seeing that maybe individual hospitals should have put a little bit more time and should be keeping more of this stuff on hand and should be planning ahead, not necessarily using straight up business principles, but healthcare business principles. So where was I going with this? I think, those are the kind of things that we're going to have to really take a second look at when we're out of the panic, crisis, pandemic mode, and try to do a little bit better, because this will happen again. I mean, it may not happen for 50 years, may not happen for 100 years. Maybe this is our 1918 pandemic and it's the same thing, but we will likely see something of some scale before too long. We've had SARS, we've had the bird flu, all these things have been within the last couple of decades. We see these things kind of pop up here and there. This one happens to be pretty bad, but we need to be prepared and do a better job next time, so that we don't have to be very reactive and talking about flattening the curve and all that stuff when the horse is already out of the barn. So, admittedly, that got a little bit off of where we were originally talking about, but that's some great conversation, and I appreciate everybody checking in. And by no means am I saying that I am 100% right. If you want to drop a note in the comments and say, hey, you big dummy, you're completely wrong about this, and here's why, I am happy to listen to it. One thing that we do not have enough of is good, solid, respectful discussion about a lot of this stuff. Everybody gets entrenched in well, I'm right, and then you start butting heads and all that stuff. So if we can have some legit conversations about this stuff, One of my passions is getting everybody on the same page so that because we have to work together. We have to be working together in order to make this stuff happen. And that includes patients or people living with these various conditions, as I prefer to say. That includes caregivers. That includes public health. That includes acute care health. That includes nursing homes and nursing facilities, and that includes dietitians. And we've got to look at the entire chain here to see how we're doing things better. So I look forward to a lot of robust discussion as time goes on. But heading back to some of the trends that are coming out of this Evidation study, of course, we know that, as I mentioned, we've got about a third of all folks who have had, in the last couple of weeks even, disruptions to their medical care. It's worse in chronic conditions. Now, for whatever reason, and I don't know if it's they didn't get enough data reported, or I don't know. I legit don't know the answer. COPD is not specifically mentioned in the set of chronic diseases here, but we know that not only was it 1/3 of all patients, but 40% of people with asthma, 52% of people with chronic pain, 45% of people with heart arrhythmia, 42% of people with depression. All of these folks are experiencing disruptions in their care, and we know that people with COPD tend to have at least one of these things. Diabetes is on here, arthritis is on here. So folks who are experiencing chronic health conditions are having more of a disruption in their care. So if you're having trouble getting to your doctor's office, your nurse practitioner's office, your physician assistant's office, any of these places, you are certainly not alone. Worse, we're seeing that about 8% of all patients are seeing disruptions in their supply chain for medications, but 10% with asthma, 17% with chronic pain, 13% with type 2 diabetes. We're seeing massive disruptions in their supply chain for really important medications. We know that albuterol has been on a shortage lately. We know a lot of that stuff has been a real concern. And then we can also start drilling down into health concerns. We see that, 20% in general are worried about maintaining their health, all through all conditions here. 42% are worried or very worried about going to the doctor's office or the hospital, including the emergency room, for necessary care not related to coronavirus symptoms. So again, that's where telehealth is going to be a big deal going forward. We shouldn't necessarily be exposing you to this coronavirus or SARS-3 or horse flu or whatever the next dread disease is, simply to get some of the basics done. We talk, I'm a big proponent of people with COPD having their own rapid response pack in the home, where perhaps you're getting sick, so why do you have to come into the office to get a pack of antibiotics and a run of prednisone? If you know it, call us and let us know so that we can do the follow-up, and then we'll say, hey, take your stuff. Why come into that? Why come in for that? Why come into the ER for all of that stuff and 6 breathing treatments, and then we send you home? Why expose you to other stuff just to give you the stuff that you can do at home? It doesn't make a lot of sense to me, and I think people are kind of coming around to that now. So here's a thing about telehealth. 40% have been able to use telehealth. 39%. 59% said they haven't tried, and 2% say they're unable to use. So, but again, these are people who are already tuned in and using an app. So if you're using one app, you're probably pretty comfortable using a different app. So that's a thing. And then of the 40% who are using it, about 40% are using live video. They're also using text and email. They lump in phones, texts, and emails into one category. I wouldn't necessarily consider those telemed, honestly. I mean, kinda, sorta, I guess, but and I know that there are different flavors of telehealth, and I see Mary Hart joining us too, who is also very well versed in the asthma side of things with telehealth. Um, she'd probably be scolding me if I didn't clarify. Yes, I know asynchronous communication, or if you post a thing and then get an answer later. I know that's a form of telehealth, real from officially, practically, but to me, when you're looking at managing these conditions, there's got to be some kind of interaction in real time or close to real time. I mean, phone visits, yes. Ideally, you're going to have some video components. So again, I can be watching you breathe, watching you cough, all that kind of stuff. That to me is really the meat and potatoes of where telehealth is going. So again, getting a little bit off track there. Um, the good news is there are some folks, it does seem to be that those folks with chronic conditions, much like they've had the greater disruptions in care, they have had greater substitution with telehealth. So that's some good news. The other big takeaway, and this was actually from the report from this, oh no, that's part of this report. Excellent. Um, Physical activity has been declining significantly as a trend throughout this whole the stay-at-home orders and all this stuff, compared with um, where physical activity was. Um, as soon as the federal emergency was declared on 3/13, and what they did was they looked at a 7-day rolling step count, kind of averaged out by individual and then aggregated per state. So they've anonymized the data. These are very much overall averages kind of stuff. And they found that overall physical activity has declined by 48%, which I get. I mean, my wife and I have a tradition. A couple of days a week, we usually get up before we go to work and go play tennis. We're fortunate enough to have a membership at one of our local fitness clubs through the university that has tennis courts. But they're closed. All of our parks are closed. We're not supposed to go anywhere. So it's been difficult to continue to find levels of activity that are enjoyable and, especially in Michigan. I know I talked with somebody earlier today in a different conference that said they've got a couple of inches of snow on the ground. Not in Michigan. We've had a dusting each of the last couple of nights, but it's cold. I'm not one to bundle up in the thermals and go for a jog. That's never been me. Probably should be, because I've been getting a little bit more stout around the middle with all this stuff. But it's concerning because physical activity is down. At the same time, we're all isolated and depressed, and our food isn't working. We're having food distribution problems. I mean, all of these things are working together. And these are things that don't always come up very well in the discussions of COPD, because we usually leave it to inhalers and quitting smoking and maybe going to pulmonary rehab if you're lucky. And as Mary points out, we've all stocked up on food, so it's all that much more temptation when you're kind of sitting around and you've got this pantry full of good stuff, or you don't have a pantry full of good stuff and you're still trying to get to McDonald's, Burger King, Wendy's, all that stuff because you're tired and scared and you want the comfort food. Again, all these things are kind of perfect storming together and giving us a lot of problems. And so we're eating too much and not moving enough. And while nutrition is certainly a lot more than that, those are kind of the basics right now that we're not catching. So these are definitely things we need to be aware of. I will say, particularly if you live in the District of Columbia, which has had the greatest decrease in physical activity. However, we're seeing greater than 50% in California, Hawaii, Illinois, Kansas, Massachusetts, Maryland, New Jersey, New York, Rhode Island, Texas. Most people are in the middle. I will credit where credit is due. Alaska, Kentucky, Mississippi, New Mexico, West Virginia, which I think were relatively late to some of the physical distancing game. So that could explain part of it. But do what you can to do some kind of activity and keep moving and all that kind of stuff. time of sleep has increased. That was coming from a little bit more than that. So we're sleeping more, we're eating more, we're moving less. All of these things coming together have been alcohol consumption likely up. Um, it seems like here in Michigan, I saw a thing where that has been documented. I don't know exactly what the validity or the provenance or the validity of that data is, but I believe that is correct. Um, again, these I imagine smoking is up. There was a comment in one of our respiratory groups about how, well, hey, why aren't we doing smoking cessation right now? Because we know that smokers are at very high risk for the severe form of the COVID-19 disease. So let's do smoking cessation. And it's like, yeah, that's great. Great in theory, but have you ever tried to change your habits in the middle of a crisis? Habits are habits for a reason because they're easy and they're comfortable. We want to soothe ourselves. So we have our bad habits, whether it's junk food, whether it's cookies and brownies, um, whether it's smoking, whether it's whether it's alcohol. And I see Kim joining in. Welcome in, Kim, from here in Michigan. Just poured a glass of wine. And I'm a believer in, I'm not saying that you shouldn't do any of these things because we all have to cope with this. And this is a heck of a time. I know, I feel relatively young. I might be relatively young. Maybe I'm just a whippersnapper, but I know I haven't seen anything like this in my lifetime. So it's kind of freaking me out a little bit. I haven't done very good habits. I'm certainly no Russell Winwood, who even, I don't even know what to say about Russell. He mentions on the feed that there's been no decrease in his house exercise-wise, as would be expected from the COPD athlete. For those of you who may not know, he literally is the COPD athlete. That is his personal brand, and he does a great job of advocacy with that. Fighting for awareness through and better practices with exercise and nutrition, who recently challenged me to a marathon in Chicago, which I don't know that I can quite pull off the marathon, but maybe if they have a 5K, we can run part of it. But yeah, I mean, it's important to be maintaining a lot of these positive habits, not just for physical health, but because these are also things that help with some of those other chronic conditions. When I have noticed in myself, and my wife will attest to this too, and I see it in the kids, when we don't get enough activity in our house, we tend to get more irritable with each other. And it becomes kind of a downward spiral. The less we do, the less we want to do, and all that stuff. And then quite the inverse. The more we do, the more we want to be active, and the more we want to go walk, and the more we want to play tennis, and the more we want to do those positive things. And we feel better. We're happier around each other. We do all these things. So it's important to find the positive coping skills, which is a thing that I do tell all my smoking cessation patients. I don't try not to make it that it's this bad habit that you need to drop instantly and all that stuff. You need to find something to replace it. You need to find a more positive coping skill or social activity or whatever it is that's causing you to do the bad thing. We can find some alternatives for that. And in certain cases, it can be okay to do some moderation. Like I said, not to throw her under the bus or anything, but Kim was just talking about pouring a glass of wine. That's not necessarily a bad thing. If that's what's helping you get through the day and it's not a problem. I mean, it's not perfect, of course, but there are certainly worse things. You're not going out base jumping or doing harder drugs or anything like that. The risk is, particularly with smoking, I have a lot of people who get down to like 2 cigarettes a day. And objectively, according to clinical practice guidelines and things like that, we have failed. I have failed as a clinician and they have failed as a patient because we have not gotten them to quit. But if you go from a pack a day to 2 cigarettes a day, it's my view that we can at least celebrate that you're doing better, right? you're doing better at managing those things. You're doing better. You're lowering your risk. We're having risk reduction. Now, I'm also very open that if you don't quit, you are at higher risk for relapse. And when a stressful time comes, you are more likely to do that thing more again, and then you've lost your progress. So the best thing is always to cease, but certainly we can find that middle way where we can celebrate some progress and encourage continuing on to quit, and celebrate at least working with some better habits. As we can't always we can't all be Russell, unfortunately. We can't be that skilled an athlete and that motivated an athlete every day, at least. Russell is a machine, and my hat is off to him. But my hope is that we can find things that work for the individual. So we've also got Chris checking in with firing off MTIs with SVN blowing mucomist all over the place. That's certainly suboptimal, as they say. Chris checking in with the respiratory perspective. Albuterol MDI is certainly a better option these days. Mucomist, I literally cringed. For those of you who may not know, mucomist is acetylcysteine, but it's the nebulized form. There's some evidence that the pill form, the N-acetylcysteine, can be somewhat effective with chronic bronchitis and that sort of thing, bringing down some inflammation. There has never been any evidence that the nebulized form does anything but smell bad, but sometimes it just gets ordered for the darndest things. And I almost cried myself to sleep when I saw that it was being considered as a potential treatment earlier on, when we're still throwing stuff at the wall of this COVID-19 deal. Because the last thing most respiratory therapists want to see is more acetylcysteine use. So, again, bringing a little bit of humor into the day here, and it is what it is. So, let's see what else is going on today in the world of COPD. This has been, of course, kind of a quiet time. We've talked about that a lot in the last couple of weeks, because we're still, there's a lot of issues with connecting with and getting to clinical trials and research updates and things like that. So it's kind of an issue. We do see some data coming out, like I said, from other sources like this, the apps that are out there. I would imagine groups like Propeller, who was full disclosure, they were giving some free devices out a few years ago in our group. So, but I'm not paid to endorse them or anything like that. I would imagine what they do is they have little monitors that go attached to your meter dose inhalers, or various inhalers. Like they have one that fits on, it's got a little rubber boot that kind of sits on the top of your inhaler like this. They have one for the Respimat device that kind of goes on the bottom like that. What they do is it's a twofold thing that they can what was I gonna say? You can help monitor and track your use. You can get reminders. If you lose your inhaler, you have an app on your phone. You can make it beep. You can do all these things. I imagine they're getting some interesting data as well. I haven't seen anything come out from them, but it'll be interesting to see what utilization patterns we see and all that kind of stuff. Mary mentions some health disparities. I think those are definitely some trends that we're seeing. Again, we've talked about barriers with low income places, whether it's inner city low income, whether it's rural low income. We already know that these are issues. And I commented on a post where, where I think it was one of the nursing groups was saying, we've written this letter to ask the Department of Health and Human Services why it seems to be affecting certain neighborhoods more and all that stuff. And it's like, well, probably because that's the way the health system works in general. We just tend to ignore that. I know John, a year or two ago, was at a rural health COPD conference through the National Institutes of Health that I watched on a webinar. Um, we know that there are rural disparities in COPD care alone. We know that there are tremendous disparities throughout all of healthcare in the rural setting. We know these things if you're in tune with it. If you're in the know, I guess is the best way to say that. What this novel coronavirus is doing is kind of broadcasting that out a little bit more and saying, oh, well, some places are having more trouble getting testing kits. Some places are having more trouble getting ventilators. And why do some places not have enough hospital beds and some places have too many, even when they're in the same state or the same region of a state? Why are those things happening? And the hope is that we in public health and throughout the healthcare sector, we can start saying, well, because of X, Y, and Z that we already knew, so thank you for finally paying attention to it. Now let's work together to fix it. So that's my take on disparities. Mary, if you have John just now mentions the behavioral risk factor survey study. I can't remember what the two S's mean, but behavioral risk factor study, which is a huge. They have a couple of different versions. Some are annual, some are bigger and every couple of years. But this is where we get a lot of our health statistics and that kind of data. Show some of those numbers if you really want to delve deep into statistics. So yes, you can look up BRFSS. You can look up, they're usually state level ones. I know here in Michigan we do one, various forms of it, I believe every year. We can really drill down into that. But again, that's not necessarily common knowledge. It probably should be. But an ongoing theme of a lot of the discussions that I've had in this group, in this setting, and with some other things that have been going on with some other projects I've been involved with, is that health communication is really tough. We look at masks, for example, and the top line message, takeaway message is always wear a mask. Okay, but why? Because when you wear a mask, for most people, that says, well, I'm wearing a mask so that I don't get sick. But with mask supplies as they are right now, we're looking at using surgical masks at best and usually homemade masks. Those are designed to prevent you from getting other people sick. But that message isn't necessarily clear all the time. It's not necessarily clear, like we were talking before about, we kind of clump a lot of groups together. All of COPD is a thing, but we know that there's a lot of different little subtypes of COPD. Now we know as we've gotten better research. So it can't necessarily be a one-size-fits-all solution. But those are the kind of things that are really tough to break down into a headline or into an infographic or into a quick snippet and engage people before they lose interest. Because a lot of this stuff, unless you are kind of a health nerd like me, you kind of get bored with it pretty quickly. And the challenge that faces healthcare going forward is how do we get this good quality information and all the context with it into easily digestible pieces so that we know that people fully understand why they should or shouldn't wear a mask, how to wear it appropriately, how different masks in different settings might be appropriate, and so on and so forth. Gloves, same deal. We talked about, well, should you wear gloves? Well, no, not really, because unless you're sanitizing your hands after you touch anything with the gloves, then you're not really doing, you're not doing, the gloves aren't adding anything except another layer. You could be just doing that with your hands. So, but again, unless you go down to the burfus, as John points out, even you really dive deeply into this stuff, you don't necessarily get all that context. So we've got a couple of things that are going together here pretty well. 2 questions coming through in the main video feed. What foods are good for you? Can't get an answer. And Russell, again, who not only is an exercise expert, but is a nutrition advocate. Physicians are saying glycemic control is important with COVID patients. Dietitians are saying high energy, high protein supplements should be given to COVID patients. Does glycemic control become difficult with these supplements? Maybe a Kelly question. Kelly is my wife. So I'm going to see. If you bear with me for a second, I'm going to see if she might be available for a question. And then I'm going to get to a little bit of surface stuff about what Karen was asking. Let me just see if I can get a question out there. Stand by. So, to Karen's point, what foods are good for you? Can't get an answer. And this kind of comes into the whole idea of, can you not get an answer because we don't know, or can you not get an answer because it's complicated? Because it is tremendously complicated. In general, well, and I'm going to back up even a step on that. Diets can be very individualized. A lot of times people with COPD need a lot more protein, or need, generally speaking, most people need more protein than we get and fewer carbs than we get, and we need to be careful to balance out the rest with healthy fats and not the unhealthy ones. Specific dietary needs have to be really individualized in general. And how you get those foods, or how you get those nutrients, can be difficult because, of course, if you're dealing with shortness of breath at baseline, you don't necessarily want to cook a complicated high protein meal. So maybe something like having some peanut butter would be good, because that's got some relatively healthy fats, depending on, and again, you have to be careful because there's a lot of unhealthy fat and a lot of sugar and a lot of all that kind of stuff going on. So you have to be a little bit careful with some of that stuff. And there's some question about whether, Russell is a very, very, very big advocate and has had a lot of success with the keto diet. And keto can work very well for a lot of folks. But unless you do it properly, then you may not get all the advantages. So it's very likely that you can't necessarily get an answer. You can't, the most likely thing is you can't get an answer because the answer changes a lot, and it depends on what source you look at. If you were to go to a clinical dietitian, if you were to go to perhaps, even like a bariatric center or something like that, or even talk to, you might have a dietitian at your local endocrine specialty place. If you were to go someplace to manage diabetes, that's where a lot of the dietitians live. You can probably get some better assessments, some more individualized assessments, straight from the expert. But in general, you're going to want to go with protein stuff and healthy fats preferentially. You're going to want to avoid carbohydrates wherever possible. You're going to want to, as Russell's saying, whole foods, not processed foods. Keep things as clean and pure and unprocessed as possible. So if you're looking at not being able to gain weight, you might be falling into that place where you're eating a lot of non-calorically dense things and expending more energy than you're taking in. And so you might be losing some of that muscle mass. And so that's where some of those building blocks from the protein are going to be good. Maybe you might want to go with like a protein powder drink or some kind of protein drink. It is again going to a little bit depend on your individual case. So Um, so I'm sorry if that's kind of a wishy-washy thing, but that's just kind of the way it is. So I do have some good news. Um, to Russell's question about physicians are saying glycemic control is important with COVID patients. Dietitians are saying high energy, high protein supplements should be given to COVID patients. Does glycemic control become difficult with these supplements? And so I get to welcome for the first time special guest Kelly Becker. My wife was the nurse practitioner I mentioned who works a lot with diabetes and endocrine and all that stuff, bariatric medicine. So let's see. This is the first time I've ever had two people in the studio here.
Oh, you can just stick to my voice and not my face. That's fine.
All right. So, Kelly, what are your thoughts on glycemic control becoming difficult with, um, oh, there she is,
Oh, there I
um,
see the delay.
high protein supplements?
um, Actually, in my practice, a lot of times we're focusing on protein. Protein has a slower rise in sugar and insulin levels than carbohydrates, and even less than protein or fats. Um, Glycemic control is difficult anytime the body is stressed, and it is important to have some control to help minimize worsening infection or complications. Um, Protein supplements are, I'm someone who's had bariatric surgery, so if we're talking about like protein shakes never make it more difficult to, well, I shouldn't say never, but um, to be supplementing with protein of any form, be it a supplemental shake or protein foods, those things don't generally make it more difficult to manage blood sugars. If the supplement contains a lot of simple carbohydrates, or the ratio of carbohydrate is more than twice as many proteins, it can be a little bit more difficult. But most protein supplementation doesn't take on that kind of ratio. So getting good protein in whatever source possible and safe and tolerated by patients, that's important for strength and healing. Um, so I don't think these things are mutually exclusive at all.
So, and also not to put you on the spot too much, but we had a question right before you came down about patient who can't gain weight. I know that's kind of the opposite of what you usually deal with, but as you and I have talked many times, in COPD, it can be difficult to meet the basal metabolism,
Right.
that calorie load. So, do you have off the top of your head, might you have any suggestions for a good, maybe like a healthy but calorically dense kind of food that somebody could use for that? We had mentioned a little bit about protein powder and that sort of thing.
Mm-hmm.
Any other suggestions for an easy to prepare, calorically dense yet still healthy food or type of food?
So if you still really like eating real food and supplements aren't your jam, I highly recommend and go to often crock pot and instant pot low carb recipes. So a lot of times there's little effort, and especially if it's all you've got so many spoons, right? So these recipes are easy to prepare. You can build, you can have them in bulk and save, but you have recipes with a roast chicken and vegetables around it, or even your pot roast or whatever you really like in a crock pot. Things with beans and different types of beans, if you tolerate, can be nutrition dense without being terribly expensive or labor intensive. So low carb crock pot, instant pot cooking, and for some people, a lot of our go-to protein quick options include things that are meat and dairy, but there are other sources that are plant-based, or some people have different intolerances. Getting your serving size of nuts and seeds and not the whole bag, or grazing all day, those types of things.
So before I let you go, two things. First of all, our good friend Bob Sapkowiak is saying hello.
Hi.
And then also, the supplement that Russell's talking about has 30 grams of carbs and 20 grams of sugar per serving. So, is that a lot?
That's sugar. How about total carbohydrate?
30. He says 30 grams of carbs
Oh,
and 20
30
of
carb
sugar.
and
So,
20 in sugar. How many grams of protein in that same supplement?
this is the infamous lag. We got to give it a couple of seconds here before. It's kind of like talking in space a little bit. You know, you've got that lag time between when you send your message out and then it comes back, and then you got to wait for the typing and all that stuff. So, while we're waiting for Russell to let us know how many total carbs are in there. Also, John Linnell saying a huge hello to our special guest star today. So,
Hi.
something we've been looking at doing for a little bit of time. This is impromptu, which is why I see the main camera has frozen a little bit, and the sub camera is a little bit color balance isn't so good there, but this was a little bit impromptu. Oh, Russell, I just switched to the wrong window. 18 proteins, 18. So we've got 30 grams total carbs and 18 protein.
So I like, as a general rule, to follow the 2-to-1 ratio, 2 carbs to 1 gram protein. So that's a reasonable mix to help prevent a dramatic rise in sugar and insulin level that will, might lead to like a reactive hypoglycemia or a huge surge. Who is recommending this? Is it a particular supplement? A very
That's
specific.
it's going to be another one. Oh, the original question was just a particular supplement. High energy, high protein supplements should be given to the COVID-19 patients.
So in the high energy, that's maybe a higher carb load than our standard. Like Premier Protein has just 4 grams of carbohydrate and lower, but some people are needing they don't have the energy or the ability to get a lot of other calories or energy. So as a rule, that would be, I think, a fair option.
That could be a really interesting discussion to have at some point. We know with COVID-19, there are so many people who have the air hunger because they have the hypoxia and they're struggling in that regard. Have we been able? Is the fatigue coming from hypoxia? Is it coming from low energy? Where is the nutritional component to that? As usual, nutrition is probably taking kind of a back seat in a lot of the research, but it'll be interesting to see what comes out of some of the critical care dietitian research when we're on the other side of all this stuff.
Absolutely.
So, all right. Well,
Does that help? So 2-to-1 ratio is my takeaway. Get ready, you're going to catch the crunch on my knees.
Mary Hart from Texas also saying hello.
Hi.
So
don't mind me, I'm in my jammies, y'all.
Kelly Becker, everyone. Hopefully the first of hopefully many appearances, and we're going to see if we can get back to the regular camera situation here. Might have to reset things, but as I've mentioned. And hopefully there we are. Yep, there we go. As I've mentioned, nutrition is criminally under discussed when it comes to through basically anywhere in healthcare, whether chronic conditions or not. We appreciate any kind of insight we can get. So, and Kelly is of course one of my local experts. So. Let's see. Just going to scroll back for a second just to see. Let's see. John did mention something. I missed a little bit. Mark Mangus Jr. has a really good energy drink recipe he suggests. Can't find it at the moment, but much better than buying Ensure, etc. Yes, I have seen that. Mark is another long time advocate and what we call post-acute or ambulatory care. Respiratory therapist, does a lot in pulmonary rehab and the outside of the hospital care. I know he has done his own homemade brew, and that's perfectly good. One of the things that I've never been an Ensure guy. For those of you who have known me for a while, I've had my own struggles with bariatrics and all that stuff. I've had surgery and all that stuff. In the run up to surgery, you have to be very careful about what your nutrition load and things like that. And so Having premier protein shakes and Ensure and all those kind of things are important, but their flavors are very limited. You've got chocolate, vanilla, strawberry generally. Sometimes you can get a little caramel. Sometimes you get a banana, which doesn't really work well for me. Um, you can get a lot of those other things, but what you can also do is just get some of the unflavored powder. I usually went with a brand called Isopure, but there's no really compelling thing about that. And what I would do is I would take that and I would take a drink packet like Crystal Light, or I found that they had old um, the soda pop called Crush. They had Orange Crush and Grape Crush and all that. Or A&W root beer. They had some of those flavor packets. And if you mix them in with the protein powder and then just water, you got kind of like this creamy flavored thing. So if you use the root beer, it was like a root beer float. Or if you had the grape, it was like a grape and cream or orange and cream, all that kind of stuff. So that was always kind of my go-to when I had to go protein, strictly protein and all that kind of stuff. So did the thingy freeze up here on me? So that was kind of my go-to. Maybe not as sexy as Mark's, probably not as sexy as Mark's, but easy to do. So I can't remember exactly what all was in Mark's blend, but in any event, we're going to. It is now been going for about an hour now, so we're going to go ahead and get ready to wrap things up here. This would be a good time to get any last questions in. Karen, you are very welcome. Appreciate you for stopping by and spending some of your Thursday with us here on COPD Navigator House Calls. We will be doing this weekdays at 4 p.m. Eastern Time. For the foreseeable future right now, I know we in Michigan are locked down until the end of the month. I know that New York, New Jersey just issued today that they're going to be shut down until the middle of May. I would not at all be surprised if that also happens here in Michigan. So we might be spending more time together than we ever thought. So if you like the show, please let me know. We've got some various ways you can show our support. The easiest way, of course, is to like, share, subscribe our Facebook page, our Facebook group, and our YouTube channel, and our Twitter feed. You can find all of them at COPD Navigator. I also haven't really advertised it much, but I did just drop a new episode of my podcast called The Potato Cast, named after my cat. This episode talks about making sure that we're asking the right questions when we're doing research and understanding the right answers. So look for that wherever you go for your podcasts, or I can drop a link in the comments if you're interested, or send me a message and I'll get that to you. And that's about it. You're always welcome to. We've got a couple of different things like a Patreon going, all that stuff. If you want to start getting into that, I'm hopeful to start raising some funds to enhance our studio here and take some time and create some other media projects. Again, I think telehealth is a huge component of the future of healthcare, but I need all of you speaking with our voice, sharing our voice together. I honestly, from the bottom of my heart, do not look at this as something that I am doing. I look at it as something we are doing. And so if there's a way that I can do things better, please let me know, because I want you to have a voice in how we do this going forward. I want you all to have a voice in how we're connecting with legislators and policymakers and doing all this stuff better, because especially in COPD, we have not done it very well. As a clinician, I say that clinicians have not done COPD very well, and that has led to a lot of the issues we see in healthcare today. So thank you for stopping by, Gene. Will support the COPD community however I possibly can. Continue to do so through work with the COPD Coalition and the COPD Foundation. I am here for the long haul. I am here for you. So tell me what I'm doing wrong and how I can do better. Also, feel free to tell me what I'm doing right. I always like to hear that. So with that, not seeing a lot. Let me check one other spot here because I forgot to check the questions and all that stuff. Tennessee until May 1st. Yeah, technically we're April 30th. in Michigan, which is functionally the same as May 1st. I guess if we really want to do stuff on a Friday, then we'll have potentially have that opportunity. But like I said, I would not at all be surprised to see some of that stuff continue on into May. Um, the key to remember, in my opinion, the key to remember why we're doing all this stuff is we need to prevent the second wave. We know that we know that you can spread this very easily even if you don't have any symptoms. We don't know exactly how easy, but we know it's pretty easy. And we know it can take up to 2 weeks, and I was even seeing some data today that says now 3 weeks, um, maybe 3 weeks before you show symptoms after you're contaminated. So the last thing we want to do is start, taking our foot off the brakes and all that stuff, and get out too early, because then we'll see that second wave. And around the world where we've seen second waves, they tend to be worse than the first wave, because we're all kind of caught off guard a little bit. So the last thing we want to do is um, let this stuff go too early, because then we end up just making it worse in the long run. So keep the faith, as it says at the bottom of the screen, assuming we haven't frozen again. No, we're still good, so that's good. As it says at the bottom of the screen, stay strong. I know this isn't easy, particularly with people who, if you struggle with going out sometimes anyway. I know this isn't easy, and I don't say this lightly, but please keep staying strong. Let us know in the clinical community, whether it's at COPD Navigator or your local clinicians or whoever it is. Let us know how we can help you and how we can support you. Stay safe. Keep washing your hands. Um, Try not to touch your face too much. All those sort of things, and stay home. Take care of yourselves. Worry about put yourself first. Try to get some support in the community wherever you can. Stay home wherever you can. Um, that's really what it comes down to. So again, I appreciate everybody coming in today, stopping by and saying hello. Your support means a great deal to me. Don't breathe on me, as Joe says. Yes, I've had some thoughts about that, getting the old Gadsden flag, the "Don't tread on me," but putting the coronavirus molecule on there and saying "Don't breathe on me." Maybe that'll help on that. Count on your faith. Count on your what keeps you going through the day. All that stuff. Stay strong. As I always like to say, take care of yourselves. Take care of each other. Keep breathing easy, and I will see you tomorrow, 4 o'clock Eastern Time, for another round of COPD Navigator house calls. So until then, take care and have yourselves a wonderful evening.